care about, and that's pulmonary hypertension.
That's
so
not true.
I apologize. So I'll talk about the Ambition trial that came out in New England Journal in August. So study overview, this was a trial that looked at using either upfront combination therapy with tadalafil and ambrisentan versus just monotherapy. It was a 2-to-1-to-1 study design, and they looked at composite clinical outcome at 20 months. So this is their primary outcome, and it was a composite outcome which had death from any cause, hospitalization for worsening pulmonary hypertension, disease progression, and then they had very specific definitions, a decrease of more than 15% in your 6-minute walk time, or if you had class 3 or 4 symptoms at 2 consecutive visits separated by 14 days. And then unsatisfactory long-term clinical response. Again, it was pretty objective the way they did that, and that's a decrease in your 6-minute walk, and then having functional class 3 symptoms at least 6 months apart, who were seen at least twice. So this is the baseline characteristics of the patient group, and so you have the combination therapy. This doesn't show up, sorry guys. This is unreadable. Yeah.
It's unreadable.
It's unreadable. Nonetheless, there are no differences between all these different groups. This is a combination therapy. This is the pooled monotherapy, and this is the individual ambrisentan and tadalafil. So there were no differences between the combination or pooled therapy when you look at all the different baseline characteristics. They looked at disease severity at baseline, looking at different pressures, looking at their index, their PVR, and a 6-minute walk distance, and end-terminal proBNP, and which functional class they were, class 2 or class 3. And again, the combination versus the pool, there were no differences in any of the different parameters assessed, showing that their randomization worked. So here's the Kaplan Meier. This is the big bang for all of this, is looking at their outcomes. There was a significant reduction in the pooled monotherapy. If you look at, if you look at the combination therapy, there's less primary outcomes compared to the pooled monotherapy. Then if you looked at ambrisentan or tadalafil, there was, again, an improvement with the combination therapy, and there was no differences between these two curves. When they looked at their primary endpoints and secondary endpoints, what they saw that the main thing that drove the improvement in this was the hospitalization for worsening pulmonary hypertension. You can see only 4% in the combination therapy and 12% in the pooled monotherapy. Death had no difference. Disease progression was the same, and unsatisfactory long-term just clinical response was about the same. Yeah.
In PH, is it similar to heart failure where hospitalization is a predictor of death?
Mm-hmm.
So,
but yeah, it is a predictor of death. Like if you get hospitalized for right ventricular failure, your 6-month mortality is like 40% for PH. But it's just it's weird that it didn't play out in the death in this part. I mean, it was average 20-month follow-up. Yes, yes. It was hospitalization for worsening pulmonary hypertension. They had to be admitted for that, not just any cause, whether it was AKI or something stupid like that. You know, it has to be a real deal. Disease burden, whether they don't have to have complete RV failure and need inotropes or anything. It just anything that would be worsening pulmonary hypertension, whether it's worsening dyspnea, worsening oxygen requirements, they didn't go through and specify for all of their patients. Right.
My question is regarding Flolan, which is one medication that's been shown to have mortality benefits.
Yes.
Where does Flolan fit in? Why didn't you compare these two agents to Flolan? Because these are expensive oral.
So the reason is, they don't say this particular, but so Flolan, if you're going to use that, it's very difficult for the patients to use. So most of the time we'll use it in patients that are class 4. These are patients that are class 2 and class 3. So getting people on Flolan and putting them with a PIC or whatever they're going to have for the rest of their life is it's a big commitment, and we usually save that until people have a really low cardiac index or their class 4 symptoms. So like class 2 or class 3 people, a lot of these people respond very well, and so then you don't have to have a pick and have them on, you know, these therapies are expensive, but prostacyclin's 6 figures a year.
You're essentially looking at sildenafil and sulfate versus these existing options, right? Would you go for sildenafil and ambrisentan if you have? Is there a significant benefit to using those two versus the more generic form?
Yeah, that's a good question. So I think the reason they did this is because they're once-a-day meds. So, you know, if you're going to use Revatio, you have to take it 3 times a day. Your compliance in this study is going to go down. So that's why they did it. Ambrisentan versus bosentan. So bosentan has higher risk of LFT elevations. Ambrisentan doesn't because it's just ERA specific. It's not ERA-NB, which is associated with the LFT abnormalities in bosentan. So that's why they did it like this. The other question is, you know, macitentan has shown a lot of promising results too. So can we switch macitentan in for ambrisentan and then tadalafil? It's a possibility, and we probably will do that. But the purist in the field will say that you need to have these 2 combinations going forward. Just looking over at secondary endpoints, which I thought were interesting, there's a bigger decrease in your N-terminal pro-BNP in your combination group as compared to your pooled monotherapy. When you look at the 6-minute walk, which had been the big outcome for most of the PH trials, there was improvements in the 6-minute walk in the dual therapy versus the monotherapy. And when they looked at the functional class, there wasn't a lot of differences between either improved, didn't change, or were undetermined, and that was played out by there wasn't a big difference in the unsatisfactory long-term clinical response in this group. So conclusions is that using dual upfront therapy had significant clinical benefits in those versus monotherapy. And so Paul Hassoun, when he was here, he talked about this, and it's very interesting. So the curves you see, the difference is initial. So there's a big benefit initially, and then they kind of go at the same rate. And so this is kind of something that we think about because a lot of patients, they'll start out on monotherapy, and then the guidelines are to say give them a second therapy after they're failing. But most of the trials don't actually show that benefit of add on a second therapy. So this might be the reason that they do better is because for some reason you're hitting the disease process early on here. And why go ahead, Matt.
Is there anything about moving kind of like class 3 to class 2, they have broken it up by pathology and severity in terms of kind of a forest plot outcome? Did you try to intervene earlier with dual therapy and show an even bigger separation?
They didn't really look at, they did look at, you know, change in functional class with the, you know, improved, there was no change in differences between who improved their functional class or who stayed the same. And it's, you know, the problem with PH is finding it in the first place. So you can't ever find somebody with PH who's functional class 1. So that's why we can get them at 2 and 3 as early as we can get them. And then now we do it dual orals right away for everybody, unless they're low cardiac index or class 4 symptoms, and then we give prostacyclin. Yeah, Zia.
PH is a disease that results from pathology, primary like PH group 1 where you have to test it. Have they mentioned in this paper how they adjusted or took into consideration that PH group B or COPD has a different mortality whatsoever?
So this was all just group 1 patients. So you had to be specifically WHI group 1 in this trial. It can be. They didn't subdivide. So obviously the group 1 patients that do worse, as you guys are referring to, are the scleroderma patients, and they do extraordinarily poor. They didn't separate out by this, but Paul Hassoun's group from Hopkins published a paper in Blue Journal where they did an open label dual oral right away, and they showed that those people do much better than what they had done in their historical controls. So it looks like for every group, dual orals is better. Not a lot that's available, and, you know, you can do some animal models to look at it, but that doesn't play out in humans. I can talk to you more about that, so I don't take in Felipe's time, but, yeah, he does. But, you know, with scleroderma, there's more, capillary rarefaction in the RV, so the RV is more ischemic, and, you know, can you control the inflammation? You know, the rheumatologists don't know how to control the inflammation that well in scleroderma, so I certainly don't. So, you know, it's a nasty disease, and when they get it, you know, the mortality for PH associated with scleroderma, like the 1-year mortality is over 50%. Any other stuff? All right.
That was essentially my PH experience in Colorado. Scleroderma, PH,